Hi, I'm Robert Byrne from the Deutsches Herzzentrum in Munich, Germany. We're here at the ESC 2011 in Paris, France, and I must say it's a great privilege to be joined by Dr. Bertram Pitt from Ann Arbor in Michigan, who's just presented some very interesting findings from the emphasis HF subgroup analysis. Welcome, Dr. Pitt, and thank you for coming here today.
Thank you.
Maybe you might remind us just up front about the principal findings of the emphasis heart failure trial, which you presented last year at AHA and which was published in the New England Journal of Medicine at that time.
Okay. Well, Dr. Zenard presented the data last AHA, and it showed that these are patients who have systolic heart failure and mild symptoms, New York Heart Class 2, and they were randomized to eplerenone 25 up titrated to 50 milligrams or placebo. And what we found in several thousand patients is that there's a reduction in the primary endpoint, which was cardiovascular death or heart failure hospitalization. But interestingly, there was also a reduction in total hospitalizations and total mortality. So overwhelmingly positive results, and the safety was quite excellent. We saw an excess of hyperkalemia over 5.5, but no serious hyperkalemia, no excess in hospitalization for hyperkalemia, no excess in renal dysfunction causing hospitalization, and to our knowledge not a single patient died due to hyperkalemia, but yet we had this total mortality reduction.
Okay. So the consequence then of this study was perhaps to extend the indication from the NYHA 3-4 functional classes that we're familiar with from Rails and Ephesus, and then to extend this into an NYHA 2 class of patients.
Exactly.
What's the rationale then for the current subgroup analysis?
Well,
and which subgroups are you particularly interested in?
Just to say that despite this overwhelming data and the previous trials, many clinicians are still uncomfortable or reluctant to use an aldosterone blocker. So we looked back in the data to try to reassure ourselves and others. One, the trial stopped prematurely, so there's always a tendency to believe that maybe you stopped at a high and over-exaggerating things. So we're fortunate to have an additional 10 months of follow-up in a subset of patients who stayed on double-blind therapy because they couldn't get eplerenone in various countries. And in addition, I mentioned the primary endpoint was heart failure hospitalization or cardiovascular death, but that only includes the first hospitalization. So with Dr. Stuart Pocock and the statistical colleagues, we've looked at recurrent heart failure hospitalizations. And then we've looked at various high-risk subgroups because these are the ones that make people nervous. We've looked at people who were elderly over 75. We looked at people with diabetes mellitus. We've looked at people who had renal disease, GFR less than 60. We looked at people with a relatively low ejection fraction, less than 30. And we looked at people with a blood pressure less than the median, which was 123, because in each of these subsets, there was some concern about the use.
Yeah. So when you look at these interesting then subgroups in terms of the primary endpoint of the analysis, what are you seeing? Or was there any evidence of interaction, or is there anything we should be concerned about?
So when we looked at the elderly, where everyone is obviously concerned about adding multiple drugs, we had exactly just about the same primary endpoint and the same safety. When we looked at diabetes, that was especially interesting, because spironolactone, which we used in RALS, has been shown to worsen endothelial dysfunction in patients with diabetes, and there's been a direct comparative trial of spironolactone and eplerenone, and Spiro raises hemoglobin A1C, raises cortisol, and reduces adiponectin, whereas eplerenone doesn't. So when we looked at the diabetic subset, in fact, there was a greater effect on the primary endpoint. We had a 37% reduction in the primary endpoint, and was even greater in the diabetics, and we saw the same safety, a little excess of hyperkalemia 5.5, but nothing else. And even more striking is the renal group, where everyone is frightened to use an aldosterone blocker, a GFR less than 60. Same benefit, and strikingly, when we looked at hyperkalemia, yes, we have an excess over 5.5, no excess over 6, no hospitalizations for hyperkalemia, no excess hospitalizations for renal dysfunction, and not a single death that we know about hyperkalemia. So that was one of the most striking findings. And of course, when we looked at the people with the low ejection fraction, it's no surprise they had the same benefit and same safety. And we were very reassured when we looked at people who had a blood pressure less than the median, 123, and they also had the same primary endpoint reduction and the same safety. So as we look across all the data that we have, we see a very consistent story, and we think it's a pretty compelling indication for the use of eplerenone in patients who have systolic heart failure and mild symptoms. And I think this data hopefully certainly has reassured us, and I hope it reassures most clinicians.
And some evidence then that the findings with aldosterone antagonists are not a class effect. You're seeing perhaps a suggestion of differential efficacy.
I mentioned this direct comparative trial. It was done in Japan, and at least in the subset of patients with diabetes, I would prefer to use eplerenone. I think spironolactone is a very good drug, but at least in patients with diabetes, this data is pushing me, at least, and I think should push others to use eplerenone in that subset.
And finally, do you think we can implement these interesting data into daily clinical practice? This is always the challenge outside of the setting of randomized controlled trials.
So that's why we did this, and I hope it reassures people, but I know from several trials it takes a long time for people to feel comfortable, but this has certainly reassured us, and I think it should be an impetus for clinicians to begin to explore this in these high-risk groups, because those are the places where they'd be most nervous, and we found the same benefit, the same safety. And when you have overall reduction in total mortality and total hospitalization on top of standard therapy, let me tell you that over 90% were on an ACE or an ARB and about 87% on a beta blocker. So this is really additive to what we have.
Okay, well, very interesting findings there concerning efficacy and indeed safety in the high-risk subgroups of emphasis heart failure. And thanks very much for sharing those findings with us today, and congratulations on a great analysis.
Thank you.